had the privilege to work with Dr. Sulaiman at hospital. When was that?
10 years ago. 10 years ago.
It was a great help in diagnosing cases with community heart and with management plans. The podium is closed.
Thank you very much. Thank you. I found myself giving a presentation that I was not prepared. It was supposed to be for Dr. Nissen, who just urgently called that he has an emergency in the hospital, so I am giving you what he gave me. I'm not stating that I own this presentation, and I have nothing to do with it in good or bad. So good luck. If you have question, you can call him after the presentation. All right, so I wish one time in fetal echo, we will scan a patient and we just get a good picture like Dr. Diana showing us in her presentation. They are so good picture that I just, where was this done? I just want to know. So fetal echo is a very steepy and very challenging area in medicine, and we every day keep struggling with looking and understanding what we are dealing with. So I'm gonna, looking at here, how often we detect. Detect is completely technology dependent and operator dependent. The more you are doing, the better you will detect. The more you know, the more you will detect. If you don't know, you are assuming, I'm seeing a tetralogy, but you don't know what is tetralogy all about. You'll see it in front of your eyes, but you're not gonna understand it because it doesn't hit your brain. So this is the problem that we have in fetal medicine overall. A lot of people scanning, and almost every single pregnancy gets scanned more than 1 time or 2 times and 3 times. And after birth, the parents will come to me and ask me, how come? Why this was not detected? Why? And I don't really know what to tell them. The doctor maybe need to learn more. Maybe the hospital need to buy new machines and so on. So it's a very difficult and very challenging. As you see, the variability of transposition as an example, between 15 and 72%, that's a huge number to decide. Why is this so huge different in different numbers? So transposition of great arteries, if you are allowing me, I want you to cross your hand. You know how to cross your hand. Can you do this? Do this, please. Go ahead, Dr. Nermeen. You're not accepted. Okay? So this is the norm. This is the norm. This is our pulmonary always in the front and our aorta always in the back. So if you want to stab anyone in the front, in the pulmonary artery, you go from the front. And if you want the aorta from the other side, okay? So what happened in the transposition of great arteries, this is the crossing. This is the whole mark of transposition of great arteries, okay? This chain become like this. So the aorta become right now very anterior and loud, okay? And that's why we only hear a single heart sound after birth. Okay, so this is in the simplest way that how we can talk about transposition of great arteries. The simplest way for all of us to understand it is just the aorta coming from the right ventricle and the pulmonary coming from the left ventricle. So it's as simple as that. It gets more complicated when you try to understand what's going on. So in fetal medicine, as you know, the other good point when we talk about fetal cardiology, you can spend 3 hours scanning and you can spend 1 minute scanning and you get all the information. So it depends if that's your lucky day or not. If the baby is listening and sitting on the proper position or not. I scan patient, I spend 1 minute, everything is good, ma'a salama, see you tomorrow. And sometimes, like again, we spend many, many hours. So this is what we call it the axial view, where you see the nice 4 chambers, everything is perfect. Unfortunately, it doesn't come when we scan with marker for right atrium and right ventricle, left atrium and left ventricle. You have to think about that on your own. So, and this is the first thing, the crossing. You see, one of them going this way, and the other one going this way. Exactly like what I showed you. So that's what you should see. You should insist on seeing this view in order for you to go to the next stage and say, yeah, there is crossing, there is no transposition, or at least very unlikely to have transposition of great arteries. And then when you go, when we start scanning, what we call it sweep. You start from the abdomen, theoretically, of the baby, and then you start looking at the situs, and then you go a little bit up, you will see the fourth chamber, you go a little bit up, you will see the three-facial view, and then you keep going, you will see that, and then you will see that. So it's one single sweep. If you are in lucky day, your lucky day, you can see almost everything with exception to the arch that need a special manipulation and a little bit changing. This is what I see in most of the report, that when they get referred to me, I look and I read what they wrote in the report, and I see fourth chamber is normal. Why did you refer the patient to me? I don't understand. Fourth chamber is normal. Is that enough? Of course it's not enough. If you are good at fourth chamber, you can detect 50%. If you are good, assuming you are good in sweeping and looking at the fourth chamber view, you can detect about 50% of the total congenital heart disease. The most important one is the outflow, which not all of us are trained, and we are not capable always to address the outflow. So when I look good, everything is okay. This is the what? The foramen ovale, and you see it. That's from the right going to the left, so that theoretically the blood is going from the other side, from the right side. And this is the aorta. Always make your home mark. Where is your home? I always take the vertebra as my home, okay? For me to orient myself and look in where I am, what I'm looking at. So the vertebrae has to be in the back. It will never change. The heart can't change from the right to left or from left to right, but the vertebra will always be there. It cannot be in the front, right? Do you have a vertebra in the front? No. I guess you have a sternum in the front. Okay, so what do you see here? Do you see the abnormality? Is it clear to you? Anyone can tell me what abnormality you see? Who's interested in answering me? I want one person to just tell me what abnormal you see. No one? Okay, so since you didn't answer me this, you are thinking very carefully because you don't want to get yourself in a trouble. This is normal. Why? Because the crossing is there. You see the crossing? All right, so you see this is the aorta going there, and this is the pulmonary artery going there. So this is a normal scanning patient. There is crossing. There is no transposition until proven otherwise. What about this? If you see these pictures, when we say crossing, it's in the same way. You cannot see both of them in one single cut. If you see one short, the other one should be long. That's how it is. When you are going crossing like this, if I cut this way, I will see this short, but the other one I will see long. So if you see, this is the aorta, always the aorta in the heart of the heart, the middle. The aorta always in the middle because it's in the back here. All right? So the aorta always in the heart, and the pulmonary artery here in the front, you cannot see them side by side like. So if you see one small and the other one is long, that's not a transposition unless somebody will tell me there is something that you don't understand about the physiology and the anatomy, okay? So seeing this picture make me relax and say there is no transposition because this is long vessel, this is short vessel, short cut, axial cut. What about this? What is the abnormality? It's the same patient basically, and then we are just sweeping a little bit up, okay? Before we were in the center of the heart, inside the heart. Now I'm the same. I didn't move anything theoretically. I'm just sweeping a little bit up, and then I start seeing the ductal arch here, and I start seeing the actual arch in the other side. So this is also how we progress, and we see that we are moving forward. I don't know if Dr. Nissen meant for me to talk like this, but I'm just taking my chance. All right, what we see here, this is what you cannot see really. This is, you need, probably in our scanning, and I think most of the people who scan in here will agree with me, one of the most difficult really is to see the arch and look at it in a very, especially with coarctation. When we talk about coarctation, it's very difficult. This is one of the things that we still miss until today and until tomorrow, until after tomorrow, because of two reasons. One of them, there is a duct still there and sometimes overlap. And then sometimes it's just very hard to get the view of the arch and make it clear. So this is, you see here the arch, you see branching coming out of it. And what we call about the arch shape, what do we call it? Huh? Hockey? Candy. We want candy. So the aorta is candy. The pulmonary is hockey stick. Okay? So it seems like a sport. All right, so candy is the aorta, and that's how you see it. You see it having branches. Theoretically, the pulmonary artery cannot have branches to the brain. So if you see it, if you see branching that you are talking about something, only the aorta can do branches to the brain. Okay, so this is theoretically is a normal arch, very nice looking. If you are lucky, that if you extend this picture here to this area, you probably will see the BDA hooking up to the area of the isthmus, and you can decide about the coarctation. So what do you see here? Is this normal or abnormal? Huh? Who said normal? Normal or abnormal? دكتور فايز اسعفنا الله يرضى عليك يا رب العالمين. موعد الصلاة 12:45, the bus in the front. If you go, you lose CME, but you get أجر from masjid. Normal? Okay, it's normal. I just want to remind you about Salah. So always the anterior portion, always the pulmonary artery, and again, you don't see them both at the same time. I'm trying to walk you through to accept the diagnosis of transposition of great arteries. So the first thing in learning about fetal medicine in general is knowing the normal. Do not worry. All what you need to tell me is one word. I do not feel comfortable. This doesn't look normal to me. I don't know what it is. It could be heterotaxy, it could be whatever, transposition, could be coarctation. Just tell me I don't feel comfortable. And honestly, at least 50% of the patient that we usually see, that's what the only main thing. I cannot establish normality on somehow. It looks suspicious to me. That's it. That's good enough. So the pulmonary artery always in the front and the aorta always in the back. They respect each other. And this is a normal view. This is kind of mixing where you see the aortic also kind of showing up. Unfortunately, there is no color. Now this one, what is this, normal or abnormal? You know, one of the things that I always see in the reports, most of fetal medicine is part of the people who's doing scanning, and they are very good at it. Honestly, I have worked with many of you guys, Dr. Muzib, Dr. Ann. They are excellent in scanning and providing a great opportunity. Most of the scan, however, doesn't get done necessarily by them. Most of the scan get referred to the radiologist, and the radiologist, their expertise really, really somehow almost very limited in fetal cardiology for a simple reason. They don't scan a patient after birth. How they are going to scan the patient before birth? They are radiologists. They don't really get to know much. I don't know. There is a few of them probably that they are good at it. So this one is normal or abnormal? 4-chamber, good. So is this patient normal? We don't know. We have to establish 50% normal. 50% of the 4-chamber anomalies, everything look in the right place. Where is my home? This is my home, right? What is my home? Main that I will always look? The vertebra, because the vertebra will never change position. It will be always in the back. All right, so this everything, look, there is a septum here, look, okay. There is a atrial septum there, which we always, we get a PFO and so on.
The axis is
Huh? Yeah, access is another thing here. I can go back to that. All right, I have to see a bigger picture to be the axis, and I have to assume the sternum will be here, and I have to assume this is the septum. So probably the axis for this patient will be proper, and I don't necessarily calculate the axis for every single patient. When you see and you do more, you don't really take your time, yeah, this axis look okay for me, without necessarily calling anything. What do you see here? Anyone? Dr. Sharif Bakiri, our adult cardiologist, adult like they always say we know everything. So, yeah.
Most of the cases I saw, there's some precardial effusion. This is normal?
Oh, in fetal? Yeah, it's acceptable to have about 2 millimeter to 3 millimeter of effusion. See, this is the smartness about adult cardiologists. When you ask them, he asks you back. So you say, okay, fine, I am the one who's stuck right now. I have to answer him. So that's what they do to avoid responsibilities, okay? So what do you see here? First of all, you don't see the two, one short cut and one long cut. You see two parallel kind of vessels. So if you see the two vessels, the aorta and the pulmonary, there is no way on earth you can see them together. No way on earth. If you see them together, that's abnormal by itself, regardless what is coming out of the anatomy. So I see valve here, and I see valve here. So this is two valves, okay? I can think more, and I say this is look like a pulmonary, and I can think more, and I say this is look like aorta, and if I am thinking more, I will know the patient anterior portion is here, and the posterior portion is, the right is here, the anterior, the sternum area is here, and the vertebrae is there, and this is more toward the right, and so on. You can analyze. You always can analyze when you see a picture of fetal echo. Keep analyzing until you get the best picture that gives you the answer. So bottom line, this is the aorta, this is the pulmonary artery, and again, we lost the way that the aorta are now in the front, and I see both of them together, so that's transposition until proven otherwise, regardless whatever associated anomalies with it. And when you go a little bit screen, I don't know if Dr. Nissen meant this, but I know he wrote it up there, two vessels few. You don't see the two vessels because they are overlapped like this, okay? Like what you see exactly. So the pulmonary is under the aorta, and you cannot see them separated in the way that you like them, because they are kind of parallel to start with, and then when you scan them in this way, they will look on the top of each other. Again, another picture, very good picture, and you see the two vessels, you see the two valves, one valve here, one valve there. This is a transposition until proven otherwise, no question asked. Okay, so I see here the arch, you can see it. Actually, I am not so comfortable clearly to comment on this, but I believe he wants to show the aorta here in the front, and it's given the branches to the head. Maybe you see it from far away better than me. So what is other associated anomalies with transposition of great arteries? Main associated anomalies, ventricle septal defect, and probably you can add to it, second to it is coarctation of the aorta, and you can add to it also left ventricle outflow tract obstruction. This is usually kind of associated anomalies that come with transposition of great arteries. And of course, coronary arteries, it's very hard for me to claim that I'm gonna diagnose them before birth. Usually we'll diagnose this. It's very important for the surgeon to know where the coronary arteries and how we are gonna deal with them. And then there is AV valve malformation, especially in the presence of phase D, because one of the valve will cross to the other side and cover to the other side. So this here, this is, we assume this is the vertebrae, and this is the apex of the heart going there. So this is supposed to be the mitral valve. This is the left ventricle. And then you can follow through this picture, and then you will see what we call ventricle septal defect. You can see it in this area. There is the two outflow, one in here, one in here. And you can see the VSD. You will see it in the next picture. So this is the same picture what is steady picture. You okay? That's my wife there, just in case you don't know her. Okay, she's making it sure I'm not going anywhere. All right, so the VSD is here. That's the left ventricle. And sometimes we get left ventricle outflow tract obstruction, where we probably need to deal with it during the surgery. It makes our surgery a different way of approach, and make the aorta, we cannot accept the aorta to be obstructed. We cannot accept left ventricle to be obstructed. We cannot accept coarctation. Anything have to do with the cardiac perfusion to the body, we do not accept it. So anything related to obstruction of the left ventricle outflow or coarctation associated with transposition, that means we have to deal with it in a very serious way. This is the picture, this is a very nice picture that will show you the VSD. The VSD always, the left ventricle and right ventricle equal in pressure. So when we Doppler it, if we put a Doppler on it, it will have bidirectional shunt. It's not necessary, don't depend on the right and left shunt before birth, because the left ventricle and right ventricle exactly the same pressure, because we are connected through the PDA, and that equalizes the whole circuit. It's always very nice to see, you see here also the pulmonary veins connected to the left atrium. Always, you can see that. So left ventricle outflow tract obstruction, we already kind of, it could be either through the VSD, going or through the left ventricle outflow tract itself. The most important probably when I see a patient with transposition of great arteries, because that's when I am going to call Dr. Anas. I'll tell him, hey, we have a patient, is going to deliver soon, and we need you to be ready because we think this patient will need Rashkin. The best way to save patient with transposition is not starting the prostaglandin, rather to make it sure they have a good mixing, not shunting. Transposition is an exceptional disease that need mixing of the blood, the red and the blue, because we have two different circuits, one in here and one in here, and we have to mix them together in a very good way. So this is the PFO. Most of the time, it's not as good as you see it in this picture. I'm very happy with it, but it's for whatever reason, transposition of great arteries, they usually have a smaller PFO, and this patient may need to have a balloon septostomy on the NICU or in the cath lab. Where do you like to do them, Dr. Anas, usually? In the NICU, yeah. So, you know, it's a theoretically bedside procedure, and the patient is done. Do not say of transposition, I already started the prostaglandin, I can't wait. No, this patient will go cyanotic more and more and more and may decompensate and die. So it's very important for us to establish, you know, this is one of the things that, you know, we are talking about establishing diagnosis. We're not going to wait until just we check the 24 hours. Remember, very, very, very important thing. Most of the patients with serious, the most serious congenital heart disease, when they are born, they are normal. They are just normal. They have all what it takes to stay normal. They have all what it takes to trick you and to make you make a mistake and make you send them home. And that's when they go home and they die coming back. And we still see it until today, and I will see it next month, and we'll see it the month after. We always get patients back to the emergency room, either dead or in the way to die, because we didn't pick up the simple thing that we are talking about, which is maybe. So when we look at this patient, we look at, you know, diagnosing or fetal anomaly in scan. Thank you, Dr. Hiba. She's, you know, remind me about the time. And I'm not going to talk about double outlet, but you can trust me on it. It's in there, and you can call Dr. Nissen. Thank you very much.